And now.
So who's laughing now?
I'm trying to get a better word of those windows so that we.
Yeah.
Right. They like this force in Kansas.
Oh,
There was no army base taking over there in space.
Yeah.
Front range, which is too bad. And it's. Nice and sunny. I know.
Yeah, it is. What, 20 minutes from there? Unless you get nasty traffic like I am.
Yeah.
Oh, it'd be bad, but weird.
Yeah. Yeah.
It's good.
You got what you sent us. No, exactly. It's, yeah. 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 No, for sure. There'll be a lot of people 4 hours. Okay, because I was like, yeah. Yeah, so,
It's about it.
we'll get it out. All right.
But just I hit it from here, so.
Yeah. Okay. Jordan. Where's my Saturday?
So if I like to talk, walk a little bit with the camera for the room, be okay to grab me if I'm wandering around over here?
Jordan said no. It won't really with you.
No, I need to stay behind the podium.
Jordan, he doesn't.
Yeah, I was gonna say, how the mic will pick him up over here.
Yeah, I've got a mic on the stand.
Perfect. Yeah, you can hand mic as needed. All right. Well, in the interest of time, I think we've got an interesting presentation and discussion ahead of us today. So I'm going to go ahead and get us started. I'm Sarah Brewer. I'm the director of our education program at Accords. I want to welcome you all today for our presentation as part of our Statistical Methods in Pragmatic Research series. For those of you who may not be familiar with Accords yet, Accords is supported by the University of Colorado School of Medicine and Children's Hospital Colorado, and it's a unique one-stop shop for faculty to conduct pragmatic research, receive various types of services and supports for grants and projects, along with incredible mentorship, training, and education in health services research. So you can see either on your screen or up here, some of the wonderful things that Accords provides to faculty and trainees at the university. And I particularly want to point out our strong methodological cores and programs and our biostatistics and analytic core who's partnered on this whole series. So thank you, Katie. A few things that are coming up as we come to the end of our academic year. We have in just a couple weeks on April 26th, our Accords and CCTSI Community Engagement Showcase. We'll have a number of community partners who have partnered with academics on research or other projects here on campus. So they'll be actually in this space. If you are interested in joining us, we would love to have you here to meet some of our partners and dream up new collaborations. And then May 20th, we have the last in our Statistical Methods for Pragmatic Research series, and we'll have Keith Goldfeld here as well. And then the last of our events for this year, we have the Colorado Pragmatic Research and Health Conference, which is June 5th and 6th. It is a virtual conference and registration is open and available online. We hope to see many of you there. We've got a wonderful 2-day lineup. I'm really excited. Hope you'll all join us. All right. Before I introduce our speaker, just a couple of brief housekeeping items. If you are online, please use the chat and the Q&A function to share your questions and comments throughout the presentation today. We will have time for some question and answer and discussion at the end of the hour. And then we hope everybody will take a minute. If you're here in the room, there are paper evaluations in the back corner. If you're online, a link will show up toward the end of the hour. We hope you'll take a few minutes to give us feedback so that we can keep providing really wonderful educational opportunities for all of you. Okay. Today, I am really pleased to welcome Dr. Michael Matheny, who is Director for the Center for Innovative in the Public's Health with Informatics and Professor in the Department of Biomedical Informatics, Medicine, and Biostatistics at Vanderbilt University Medical Center. He's a part-time primary care physician, physician scientist, board certified in internal medicine and clinical informatics, and associate director of the HSR&D Vinci at the Tennessee Valley Healthcare System. You might be able to decipher that acronym for us at some point. He's an elected fellow of the American College of Medical Informatics, elected fellow of the American Medical Informatics Association, elected member of the American Society of Clinical Investigation. Dr. Matheny's work has focused on developing and adapting artificial intelligence and machine learning for medical product active surveillance, algorithm vigilance, probabilistic phenotyping, natural language processing, and risk prediction modeling. Please join me in welcoming Dr. Matheny.
Thank you. Thank you very much for that kind introduction. Really appreciate it. Also, it's really great to be here. It's been many months in the making since Katie reached out and invited me to the group, but just want to thank Accords and everyone for your time today. So I've got a lot I'd love to talk about. I'm going to start here and I will wander because I always do. I wanted to talk a little bit about the opportunities and challenges for the use of artificial intelligence and machine learning, particularly I use the term population health informatics, but that sort of fluctuates somewhat almost into public health. And then you'll see sometimes fluctuates down more into what you would consider a typical clinical informatics frame. So no conflicts of interest. All of my funding is from the FDA, NIH, and the VA under a variety of different mechanisms. So learning objectives today, which all presentations of this sort have to have, are we're going to talk a little bit about artificial intelligence and machine learning algorithms, some of the challenges that are being faced in healthcare implementation and delivery, talk about sort of some of the key issues that we run into in a couple of our work, overview of the life cycle framework for a way that you can think about implementing AI and ML in healthcare. And I'll give you 2 real world examples for research projects that we've been doing to sort of frame the discussion. And so, you know, a lot of us at Vanderbilt have always liked to quote Bill Stead's sort of National Academy of Medicine, sort of complexity of medical information exceeding the cognitive capacity of humans. But I went on the search for actual data to try to characterize that. And so one of the things that I found sort of really, I think, puts it in perspective for me is the growth and complexity of the clinical practice guidelines. So if you look at, there was a nice review article that basically looked at the length of clinical practice guidelines in oncology and the number of references and pages that were required in order to sort of characterize these. And what you see is essentially an algorithmic growth in the number of pages and the number of references required in a number of different oncology disciplines. And this is just one small slice of what we're dealing with, but we're dealing with an explosion of medical knowledge that providers and healthcare professionals are responsible for. And so you couple that with what continues to be a really resistant finding in literature and across both inpatient and outpatient domains about variability in care. And I don't want to overstate this in the sense that, you know, a lot of variability is intended. You have provider preferences, you have patient preferences. You actually only have about 5 to 10% of clinical healthcare that is evidence-based or guideline-based care delivery. But even if you look within that framework, on the left, you have people with coronary artery disease or heart disease equivalents who should be on a statin, you know, guideline A, very strong evidence. And you look at huge practice variability across the country for rates of prescribing for that. And then you look at another grade A guideline recommendation, people with emphysema or chronic obstructive pulmonary disease. You look at basic bronchodilator use in that population, which is sort of the first thing that you're giving these folks. And you see huge variation in people with diagnosed COPD and the rates of inhaler. Some of that could be driven by lack of symptoms, but for the most part, you shouldn't see that level of variability. And so, you know, the press, the medical literature, I mean, there's all of this, our AI to the rescue. It can solve many of these problems for us. And I would say maybe, and you'll see how where some of it works and where some of it doesn't work right now the way that we want it to. So looking in the literature, if you're looking at clinical decision support, there's really some sort of landmark publications, but one of the things that I love to pull out is that, you know, there's a general sense that artificial intelligence and machine learning can help us. So we have provider burnout. We have challenges with information synthesis. We have challenges with trying to sort of direct appropriate therapy. So there's a lot of literature around how AI can help sort of synthesize information, provide the cognitive support. And a lot of the burnout right now is from basically a huge volume of reminders in primary care and clinical care that are basically like, if A, then you must do B, without any context sort of relevance for individual variation among patients. And so there's a hope that increasing personalized medicine and tailoring these systems with AI can help provide better care and help reduce provider burnout. And so this is a little bit less true in 2024 than it was in 2020 or 2021. But if you look at the literature for risk prediction model publications, you just see hundreds and hundreds and hundreds, thousands of risk prediction models being published. But when you look at translations of models published to actual those that are being used in some population health office, back office or front end clinical deployment, it's a much, much smaller slice of those models. And so one of the questions you would ask is, well, why is there such a huge difference in model development and model actual use and deployment? So one of the things that I want to sort of add in to the discussion is also an issue around, for many years, there was a lack of sort of a framework for how to sort of produce models in a standardized way. So you ended up with all these challenges where models will be built in different ways with different variables and reporting different characteristics. And so even understanding how to use them in what situations and under what sort of outcomes and what intended actions that you want to use them for was challenging. And so thankfully, in the past probably 5 or 6 or 7 years, we've seen a really growth of sort of framework recommendations around how do you build models? How do you appropriately evaluate them for bias? How do you score them? How do you sort of standardize the inputs and outputs so that they're more usable and generalizable in downstream use? And that being said, there's some really high profile problems that we found in use of supervised learning algorithms. This is a really famous example. I'm sure many of you have heard of this one. It's Obermeyer in Nature, essentially where a large healthcare payer essentially built a national risk model. They basically predicted healthcare utilization as a proxy for resource choices around who to give extra resources to for healthcare delivery. And what they found was a racial bias that because Black patients were getting less healthcare utilization, the algorithm actually weighted white patients to get more healthcare utilization because they were using more. And so this article is a really great landmark article that showed when the AI data science team worked with the organization to actually remodel the variables to be a clinical outcome based instead of healthcare utilization based. They were actually able to eliminate between 70 to 80% of the bias in the algorithms and redeploy them. So it was a really good example, not only of problems that you have to look for. And I think, this was 2019. And since in the 5 years since then, there's been a much more rigor around expected sort of bias assessment and population diversity, equity, and fairness in models, definitely more awareness. And this was one of the sort of the really good bellwethers for that. So work that we actually did back in the 2016 to 2019 range. Sharon Davis was a PhD student at DBMI at Vanderbilt. And basically, we took the national VA data and we assessed a bunch of different risk prediction models, both for acute kidney injury and for mortality, essentially looking at different machine learning models for how they performed under different circumstances. So we looked at how the models sort of fared under event rate shifts. We looked at how they fared under association variable shifts, and we looked at how they fared when the case mix that the healthcare system was seeing shifted over time. And what we found were that all the models were pretty susceptible to essentially declines in function and capacity over time in any of these. In fact, the only really sort of interesting finding here that says that that's not always the case is that the deep learning sort of neural network models actually were able to sort of adjust inherently for case mix, but under most of the circumstances, these models were slowly degrading over time. And another issue is, you've seen in the literature where risk models that incorporate race explicitly have problems. A good example is the glomerular filtration rate for kidney function. There was a race-based calculation that ended up not having good grounding and evidence. And what the actual impact of that was is that Black and African-American patients were less likely to get on the transplant list, were less likely to have certain interventions to deflect their chronic kidney disease progression. And so what I'm saying here is there's a real critical need, not necessarily to explicitly incorporate race into the model, but certainly it's really important to have it aware so that you can assess the performance of the models for a variety of different clinical subgroups, racial and ethnic and cultural groups, in order to ensure that the algorithms are actually performing in a fair way across these groups. And so this is an example that was published. Actually, I don't think it was published, but it was an example that shows how you can adjust an algorithm to actually be fair for each of the subpopulations of interest, rather than if you're not evaluating it, you may end up with inequity. And so you can't have an AI ML talk without generative AI. And even though the work that I'm going to be talking about today is 15 years in the making and uses many of the more traditional models of supervised machine learning that we know and love, I put this up there because when I've been watching sort of the Gartner AI hype cycles for a number of years. If you look at 2019, basically the hot topics were deep learning, natural language processing, machine learning. You fast forward to 23, it's all gone. There's none of that on the Gartner hype cycle. It's just generative AI, and amusingly enough to me, general intelligence, AI, which is sort of a concept that is actually conceptually aware, which I just want to say generative AI and large language models are not. They're a mathematical framework that just predicts the next token on the basis of an insanely large amount of data. And believe it or not, I actually get that question still in conferences and webinars about sort of the cognitive capacity of these tools. But I'm going to get off on a soapbox if I'm not careful. So, it's really important to also know that, these methods, even though they're a completely different framework of tools, they're not immune to these issues of drift and performance problems. So not only are these tools known to be limited when they're applied outside of the context of their development, but they actually continually evolve. So the ChatGPT of March 2023, so there's a group that basically looked at prompt engineering and basically assessed tasks in a large language model, the GPT, and tested it in March and then tested it again in, I believe, August or June. And what they found on these were that the performance was changing over time. So these tools are being updated with new information across the web and other sorts of sources. And so you saw performance increase, performance decrease. And what that means for healthcare applications is really critical. It means that if you have an application that's an online application and you're trying to deliver healthcare where you're actually trying to do prompt engineering and actually deliver that, you may have drift, not only in the data and in the population that you're seeing, you may have drift in the actual generative AI algorithms that can change the performance characteristics of your tool and create safety issues. And so it's something that I don't think is talked about quite enough, in the sense that in many cases, a large language model that is an open source LLM doesn't do as well as some of these, but because it's static and you choose when it's updated, it allows for stability for some healthcare applications. So implementation challenges. So when you're thinking about AI and deployment in health and healthcare settings, there's really a lot of issues in actually implementing these tools. So first, you have issues around integration into the right workflow, and I'll be talking about that a little bit more. You've got challenges. So the algorithm does its thing, you get the output, that's great, but you have to incorporate that into data visualization, data interpretation, synthesis, and in a way that's sort of conceptually and cognitively aligned with the user. And that's a whole nother field that has nothing to do with the core algorithm, but is even more important sometimes than the algorithm itself. And then there's also the challenge of translating these prototypes into clinical production, which is a challenge unto itself. And so some of the work that we did in the National Academy, I was able to lead a publication in 2019 where we gathered about 30 experts around the country and wrote a number of recommendations and sort of summaries for AI in healthcare. But one of my favorite parts of that publication was actually we took a group of people and we designed an AI lifecycle essentially incorporated ideas from the learning health system, user-centered design, implementation science, and human-computer interaction into sort of an overall sort of life cycle framework, going from conceptualization of first the problem that you're trying to fix. So you don't go with a hammer in search of a nail. You actually identify the problem that you want, make sure that AI has an application. Like there are plenty of things in healthcare that need a human intervention or need a process change, not necessarily the implementation of an AI algorithm. And so I don't have time today to go into a full detail, but I will say that sort of funnily, I spent all of my training and early career right there in that box, learning how to do that. And what I learned in recent years is these are the most important parts of developing AI and effectively implementing it to actually implement practice change. And so I say that just because I want to call out in the examples I'm going to show you that the partnerships I had with my qualitative research fellow colleagues and collaborations that I had with implementation scientists were hugely valuable in the success of those projects. So I'm going to take you through two real-world examples from our work, sort of trying to highlight some of the challenges that I mentioned here. This is actually the culmination of 15 years of work. So this started as a career development award in the VA, and then an IIR in the VA, and then ended up in an IDDK R01. And it's both heartening to see it sort of go through that life cycle, but it also was a little disheartening to see that it took so many years. I would argue that research in AI and ML right now is on a much more rapid time cycle. So this is work that we did looking at implementing a system to sort of support improvements in acute kidney injury following cardiac catheterization. And if you look at the literature, essentially, there's about 1.2 million coronary angiographies done a year where they actually inject dye contrast in and basically look in the arteries of the heart, assess blockages, potentially do interventions with stents and other balloons to sort of ameliorate those. But the contrast and a number of other factors sort of create a situation in which kidney damage is likely. And in fact, in these cases, up to 10 to 15% of patients experience AKI. And what you can see is that it's not just a lab test. There are also sort of excess morbidity and mortality that comes along with that outcome as a proxy. And so while some trials were not significant, there's been a general trend towards certain key things in the literature that are generally supportive of reducing AKI, reducing contrast volume, encouraging patient hydration, both IV and oral, routine monitoring of function before and after, because if you don't measure it, you don't know if it happened. And then other medication optimization strategies, such as ACEs and ARBs and other things, have generally been promoted. But when you look in the literature, those are pretty well clear, but if you look at actual implementations and standardizations of those strategies, you see that they're highly variable. And so what we did was we did a study in 20 centers in the VA, and this is sort of in a diagram for those that aren't familiar with the VA. It's a healthcare system delivery national for veterans. Essentially, it's a healthcare payer, but it's also a healthcare delivery organization. And there's about 70 centers in the VA that have cath labs, and we partnered with 20 of them. If you look in the VA alone, you think the VA would be a relatively monolithic organization with a relatively standard electronic health record, standard data stream, standard care delivery. And what we found in early work was that the risk-adjusted variation in kidney injury in patients was highly variable across sites. So you had some sites that were operating at almost 0.5 O to E ratio compared to the national average, and you had some that were operating at almost 1.5. And so this was an opportunity to essentially assess and evaluate and potentially support reduction in care variation. And so, as I mentioned before, I got a little bit ahead of myself. Even though there's numerous trials, there's really a lack of implementation and evaluation of these. There's a lack of sort of implementation science framework application to this. And so we sought to basically develop an integrated approach that combines sort of machine learning, supervised machine learning, data visualization into sort of an informatics dashboard, coupled with quality improvement and implementation science coaching, where the team at Dartmouth, led by Jeremiah Brown, essentially did the QI and implementation science part, and the team that I led in Nashville essentially did all the informatics and data science pieces. So what we did is we had 20 hospitals, and so we worked with a national CART program here in Denver. It's been sort of a long-term collaborator and supporter of our work over the years. And we randomized sort of sites to either neither the informatics intervention nor any intensive coaching. So there was like a technical assistance, which is they reached out and sort of gave them some baseline information and gave them sort of all the written materials, but didn't sort of do an intensive coaching. There's ASR, which is sort of the informatics dashboard that I'll show you in a moment. There's just that. There's just the intensive quality improvement coaching, and then there's both. And our primary outcome was any acute kidney injury in the 7 days following cardiac catheterization. I mean, we of course excluded people that were already on end-stage dialysis and we discluded any people under the age of 18, and we included only those that had coronary angiography or PCI, which is an intervention that occurs during coronary or angiography. And so this is the team that did a lot of the work. And so they were just tireless in sort of setting up monthly meetings during the active intervention phase, working through the pieces. And one of the things I really liked about this trial is we didn't require a truly standardized process change by any of the sites. Sites could do anything they wanted to. They could completely ignore us. They could change one thing. They could change 3 or 4 things. It really depended on the appetite and the interests of the local site leadership or what they chose to do with the information we're giving them. And so you can see here there's a process. So I'm going to call your attention now to the timeline. So what you'll see here is we started right before the pandemic. And then we basically 12 months of the 18-month active intervention phase were in the middle of the pandemic. So we'll come back to the impact that had on the trial. And then we've done a sustained phase that I'm not going to go into today, it's still unpublished, but sort of occurred much more recently. Oops. And so this is the informatics dashboard tool that we built. And so we essentially do an iterative process with interviewing the users and getting a sense of what they wanted. We essentially built a dashboard that had a statistical process control type view, which allowed the users to sort of see their performance ODE over time in their individual site. We also benchmark them against the group of VISN, which is like a 6 to 8 hospital group, the national, and then the sort of region of the VA. Down here in the bottom, which we'll get back to in a moment, is a risk-adjusted sequential probability ratio test framework that allows for like a prospective surveillance with a threshold alerting for if their center goes above a certain expectation for the API, and uses the machine learning underneath to do the risk adjustment. And then the bottom, we had basically a case list that every case that came through the VA, they essentially got all the covariates in the model, they got outcomes of interest, they got assessments of the risk of those relative to the national risk adjustment model. And this is the team at National that led that work. Sharon Davis did all the modeling, Dax did all the UI and visualization, Chad did all the data management. So when I said this sort of took 15 years, the second stage of this was work that we did here, where we went into the national VA across all 70 sites. We built the risk prediction model. At this time, it was LASSO, although when we went back to do this in the trial, we evaluated random forests and found that this particular instance didn't have much of an increase. And so since the providers were really interested in an intuitive assessment of the weights of the model, they've given the small delta in performance, they prefer the LASSO version. So we stuck with that. What you see here is essentially observed or expected over a spectrum of risk. And so it's really important when you're doing risk adjustment that it's not just an AUC or discrimination capacity, but you actually want to assess your calibration and performance of your model across the spectrum. So you can see the event rates here. So for stage 1, it's about 14%, which is fairly common. And then if you get down into severe AKI, you're at about a 2% stage. So at the time, it's funny how things change over time. So at the time, the literature wanted external validation. So we externally validated in the New England cohort. But I would say actually that the current field really is moving away from external validation to a concept that you really need to sort of consider local adaptation of the model in any environment that you're putting them into. And so there's less of an emphasis on external validation and more of an emphasis on temporal validation and decay of drift over time, so that you can assess sort of the temporal assessment of your model in your own environment, then you show that the process and framework that you're developing are deployable in other environments. And we were talking about that as well. So this is actually another example where a group took about 15 different risk prediction models. And remember, I said tons of models get published, but not very many get implemented. So they basically did a review and applied this in the external data set in Europe and found that, you know, our model essentially did very, very poorly for a strict definition of AKI, and then we did quite well for a loose version of AKI, which again, I would say is less important to show now than it was then. And so we knew we had problems with the model. We knew that depending on the environment, it might not work. We knew from Sharon's work that there was drift over time and there were problems. So we needed a way to essentially build that framework into our prospective clinical trial. Am I too low? See, I told you I have to wander. I can't not so so if there's feedback that doubles from the mic, is it okay to turn this off? Well, hopefully there won't be. So if anybody's online and you hear a double feedback from the two mics, let me know. So there were problems with EHR, there were problems in the data encoding. So we actually noted variable drift between sites that were a problem. We also noticed that the retrospective data wasn't always in alignment with the near real term sort of prospective data. And obviously we showed you before that there's data drift. And then 12 out of the 18 months we were operating in the pandemic. And so one of the things that I feel very fortunate now, particularly in the setting of the pandemic, is Sharon had developed a entire framework around how to surveil machine learning models, look for drift and all these different characteristics, and then actually declare a threshold where the model needed to be updated along a threshold of, you know, just an intercept adjustment versus, you know, coefficient adjustment versus flexible and versus a full remodeling. And so we actually implemented that sort of the machine learning models, surveilling machine learning models within the trial. And it was able to successfully sustain the model performance essentially through massive data shifts. And so what I didn't show here is that the cath labs in 2020, they all shut down for elective procedures in the VA. So for a period of about 3 months, the case mix and the volume plummeted, case mix shifted, and then it only gradually sort of came back over time into 2021. If we hadn't had this sort of framework in place, everything would have broken. Then the model system would have completely degraded, and we wouldn't have been able to complete the trial. So I still thank her occasionally for her work enabling the successful completion. So now the money slide is the results. So among 20 sites looking across the different 2x2 arms, we found that the sites that had both the intensive quality improvement coaching and the informatics system support have an adjusted odds ratio of 0.54 for the occurrence of AKI after the cath. The only sort of slight shadow in the results was that for the CKD population, you actually don't see a significant. So you've got a group that's everybody, and that does include the CKD patients. And what we think is going on there is that the CKD patients were already at significantly increased risk for AKI. And so there already were some pieces in place at the local sites to focus on that group as a focus group. So the delta improvement from all the intensive quality improvement coaching had less room to go. And so the changes that were made in the processes across the different sites had more impact in the global population. So some unresolved challenges from this that I took to heart. So one is, and you'll see this in a moment, is so we had an analytic framework that was grounded in statistical process control, which was basically itself an engineering discipline that was then adapted for healthcare to enable heterogeneity in the patient and provider populations. But there was a lot of challenges in the providers to understand that. So, and so I'll talk about that in a minute. And then even with direct education, there's a lot of barriers to understanding and interpreting the charts. And so what we found in post-qualitative assessment was most useful parts that the providers found were the case list in the bottom, where they could actually see all their patients, see the outcomes, see the risk model scores, see the weights, the coefficients of the variables, and they were able to use that to actually help to iteratively adjust their process care plans. But the part that I was really looking forward to having an impact was the statistical process control and the statistical methods that I love. But what I would say is need to go back to the drawing board and make it more visually appealing. And so when I was doing early work in medical device post-market surveillance in the late 2000s, early 2010s, we did a lot of this sort of work where you basically, chart your signal, you look for deflections, you declare your rule. So we had it all. We had an adjustment for alpha error. We had, we had alpha spending. We had, formal hypothesis testing, and we had basically a whole odds ratio threshold detection. And but it just wasn't clinically useful to the team. The O to E was much more intuitive and easier for folks to sort of keep around, even though this was the more statistically rigorous way to detect elevation and outlier status in the population. And so the trial really stood on, in my opinion, not so much the informatics infrastructure, but it stood on the goodwill of the actual clinical cath lab leadership and buy-in from the CART National Cardiology Group that helped facilitate everything. And so what I took from this trial was that sort of a mix of data science and sort of clinical championship and implementation science are really required to be able to effectively deploy these solutions and evaluate them in the healthcare system. So in conclusion, clinical impact was that we were able to actually make a significant decrease in acute kidney injury. We made a actual substantial outcome difference in patients' lives, which was one of the first times in my career I was actually able to say that. So I've done years of work in informatics, but to actually see something impact clinical production was really, really rewarding. And that we're hoping to scale this to other environments. But it looked like on the face of it that the way we did the architecture and the framework would allow itself to do that. And in informatics, we found mostly challenges that the risk model, maintaining the risk models are challenging and require actually a fairly sophisticated framework around the model to surveil the model and keep it updated. And then summarizing complex clinical data in a way that is intuitive, useful to the clinician workflow can be quite challenging. So I guess I should I'll go on to the end and we can have a bunch of questions. I thought about stopping along the way, but I'll go ahead and go on to the next example. How much time do I have? About right. Okay, excellent. All right, so the other example, now we're going to go from the population view, from the provider-facing view, into much more of what you would consider a typical clinical informatics trial dealing with clinical decision support. So Salim Virani was a chief of cardiology in the VA at Houston, and he was on the clinical practice guidelines for this. And he had a vision where he really wanted to help folks that had heart disease and ASCVD risk, help sort of improve statin prescribing, because it was shown, as I showed in the literature early on, there's huge variability in the rates of using this. And for statins in particular, there's a situation where you get muscle aches and you get muscle cramps. It's been highly publicized. And so you get people refusing to take this medicine. And so you end up with all this variability in the application. And so, I'm going to just go to that. And so the use of high intensity statins really remains low due to a number of practice barriers. And so the ones that so there's a number of drivers related to that. Some of them are sort of outside the influence of our group, but we basically wanted to design a trial and an informatics support system that would help us address the therapeutic clinical inertia, make it really remind patients, providers at the time that they wanted to be reminded, and to try to address some of the side effect issues. And so, again, I'll sort of direct you back to the National Academy of Medicine sort of life cycle. So the important thing first, before you go and build the whiz-bang tool, is to go to your user community and make sure that you're solving a problem that they want solved, that the outcome that you want to address is what they're willing to see addressed, and that they're willing to engage you in development of the workflow intervention process. And so that's what we did. They basically, Dr. Ahmed basically led a group that evaluated patients and providers in both Tennessee Valley National VA as well as Houston VA, essentially assessing axes of interest and need for information synthesis. And so I won't go into too much detail, but essentially your qualitative process of interviews, standardization, and coding that basically emerged these key areas related to dealing with perception of side effects in the statins. And so we wanted to design an informatics solution that essentially sought to improve the rates of statin prescribing in people with known cardiovascular disease. But we needed to do it in a way, so there's a couple of key points. One is we needed to do it in a way that minimized interruption to their workflow, or they would just be yet another thing that, and I'm a primary care physician part-time, so, you know, another clinical reminder clinically doesn't excite me, but what does excite me is if you do it in a way that minimizes false alerts, you do it in a way that provides clinician the information they need instead of them having to go and dig for it. My hope was that would help providers in the end. So we randomized 27 primary care clinics in August of 21, which again, note the timing of that relative to the pandemic. We excluded people that didn't have established cardiovascular disease. We allowed providers to opt out at any time through a notification to our research group. We essentially randomized to intervention sites and usual care sites. And then, so the intervention sites would get essentially an integrated natural language processing tool that basically reviewed the text notes, pulled out information relevant to the statin prescribing, side effects, patient preferences and provider preferences, and would basically assemble them into a personalized care note that we delivered to the provider, or basically no intervention, essentially usual primary care. And so our outcomes were pre-post change and high-intensity statin between the intervention and usual care sites. Sorry, let me go back one there. And so some of you I know have talked to Ruth, and so the colleague to Ruth Reeves is Glenn Gobble here, and the two of them basically developed a natural language processing solution, which is not deep learning and not sort of the new generative AI, because this was developed. So in order to get something into trial, you have to go back 3 or 4 or 5 years in the literature, you know, to develop the NLP systems. And so what they did was they took an existing tool, adapted it to the VA to be able to extract these information. And essentially, you can see that the workflow here is essentially pull documents out of the data warehouse, pull EHR data out of the data warehouse, build a work monitor that on a weekly basis had to process the NLP data, transform it, integrate it with the structured data, provide it to a notification service, which then generated the user documentation that would then be delivered to the production electronic health record system for their review. And so this is sort of an adaptation. It shows all the process. I won't go into too much detail other than to say, essentially, it was a mix of rule-based and sort of supervised machine learning NLP adaptations in which the tool, we basically had about 1,150 notes that were manually annotated across this. We developed the NLP adaptation on 640 notes and then tested it in an additional 512, essentially using both structured and unstructured data to be able to determine both side effects, reasons why they may or may not have been on it, reasons why they stopped, and potentially serve those up to clinicians as consideration for restarting medicine. So this is the performance of the NLP tool on that corpus. So essentially, if you look at structured data only for reasons that they wouldn't have been on a medication, you essentially see pretty good performance, really. But again, when you're talking clinical tailoring and trying to get down to the predictions for an individual patient, we wanted to try to boost that as much as possible. And in this particular case, when you added the NLP to the structured data to determine adverse events and reasons on a medication, you see a significant discrimination bump and basically a significant improvement in true positives and true negatives relative to the prior structured data in order to support improved accuracy. And so I would say, you know, I would actually say this is probably still insufficient performance if this was an autonomous agent, but it's not. It's used as a support tool to sort of give to clinicians, and then they can review it and then make the decision themselves. If you're looking at autonomous AI agents, you're looking at like 0.97, 0.98 sort of range that is almost never achieved. And so anyway, I won't get in. That's a whole nother conversation that we can have. So as I mentioned before, there's the intervention workflow, and essentially reminders were given to clinicians about 2 to 7 days before their visit. So we basically linked the notification service to try to identify when they were going to see their primary care provider. Wherever possible, we tried to deliver the intervention right before they were going to see them, and to reduce alert fatigue, because the clinicians were really worried about us just dumping 100 reminders on them in clinic. We limited the notification to 3 unsigned notifications at a time. So if somebody got 3 and then they ignored them, they didn't get 3 more until they addressed those 3. And that was, even with that, we had some challenges. And essentially, you can see that it's basically a centrally processed note, and then basically we deliver all this information to them. They could opt out at any time. And so this is an example of the actual documents that would be given to a provider. So you see basically guideline recommendations. These are what we recommend. And then you start getting into the user specific context, like what your upcoming visit is, what your prior visits were, notes that were actually, so the structured data that makes you qualifying for this reminder, and then something you don't see, but we had in some patients were basically the notes where the statin side effects were found, and then basically a date timestamp and a note title that the provider could go back, but it actually told them, hey, these side effects you found, and so you may not want to restart this, kind of up to you. So these were delivered, and then the usual care was basically no change to their workflow other than the dashboards that every primary care clinician has available to them, which actually do have a lot of data around what your compliance rates are and what your statins are. So it's not like they couldn't see this information, but it was sort of very asynchronous and optional for them to look. So we ended up with about 18,000 patients in one arm and about in both sets, 117 versus 128 clinicians. We randomized in clinics so that you wouldn't have a bias from learning that could potentially cross-contaminate providers within a clinic. And essentially, what you have here is that about 41% of the patients in the intervention arm had an NLP signal that showed that they had prior adverse events to the statins. So this is higher than in the literature. But I think what you see is that with the press and everything sort of really sensationalizing statin side effects, you saw an increase in the reported rate of adverse events in recent years. And so that's some of what's going on there. And then the second item was a limitation. And so since we anchored our intervention to try to deliver the note right before the provider saw the patient, there's only a portion of patients that qualified for that. So we had the ability to also deliver them asynchronously, which is like any number of days between, like if you're seeing somebody every 3 months, you could get something a month and a half before the next visit. We tried to avoid it, but we were allowed to do it by protocol. And so in the end, though, what we didn't expect was that we thought this was going to be 75% and this was going to be 25%. But because of the limitations and throughput, the low volume providers like the resident attendings that had smaller panels, we saturated them quickly. And the full provider panelist private care who had a ton of patients, if we were only giving them 3 a week, we just never could get through all of those patients to intervene for them. So over time, we also had a fairly significant dropout, 31%, which is pretty significant. And it was mostly in the early stages of the intervention. I can talk a little bit about what I thought was going on there. So there were a couple issues for providers. So first, there were a lot of competing demands. And again, note that this was not during the early part of the pandemic, but this was still during part of the pandemic where telehealth was being prioritized. Some clinics were still flexible. Patients were still electing not to come in. And so you were still not at what I would consider to be a pre-pandemic workflow state, nor a post-pandemic workflow state. So they had significant alert fatigue because the VA has a lot of regular clinical reminders that they're being required to address. The other issues were informatics, were data science. So we had a 2 to 3 day lag because of our processing pipeline. We ended up processing the data, but it was 2 or 3 days before we sometimes delivered the note. Well, what happened in that 2 or 3 days where there were interval med fills. So we had patients, the provider's like, hey, I just filled the medicine. Why are you giving me the alert? Or we had patients that passed away in the interim or other things. And so, you know, I think in Cerner or Epic, you could probably get this down to near real time, but we just didn't have the infrastructure capacity to do that in Vista CPRS, the electronic health record we were in. And the other thing was, I think, an improper alignment with primary care. So the PI of the study was a cardiologist and a sort of statin specialist. At the time, I really felt like from a primary care standpoint that if we tried statins, we tried a couple different statins, they didn't work. We referred them to lipid clinic. Our job was done. Primary care had done what we were supposed to do, and we were sending them to the specialist. That should count for us. The other thing that was happening is PCSK9 inhibitors, which are like an injection medicine that you can get that are really expensive. They're really good, but they're not a statin. And so the care guidelines had not quite been updated to sort of recommend those to follow statins, even though in practice that was already happening. So the PI said, well, because it's not in the guideline right now, we're not going to put it in. But I would get feedback from primary care providers saying, hey, they're on this new agent. I mean, we've already failed statins. I don't need this alert. So I would say there's an opportunity in this trial for additional denominator tailoring to sort of manage the appropriate clinical workflow from a primary care perspective. So that was a lesson learned. So now onto the good part of this particular trial. So what we found that was really interesting is that during the pandemic, the actual rates of prescribing in this medication class went down. So what the intervention effectively did was, to some extent, prevent the decline in the usual care group and or sort of reverse it to a small degree. And I thought that was really interesting. It makes a little sense if you think about it. Patients aren't coming in as much. There's more telehealth. They're not getting sort of as regular care. And so this was sort of a prompt and a way to help the clinicians and patients maintain that particular medication. So in the end, there was an overall impact, although modest, for improvement in the prescribing and between group sort of comparison. What I take home though is this page. So we're doing another study as a follow-on to this one, and these are the real lessons learned. So if you look at the group, only about half of the intervention arm even got the intervention, but we had to sort of obviously do intention to treat analysis. So what you see here is in the subgroup analysis, you see either very little change in prescribing or negative for usual care. But in the intervention group that actually got the full reminder and the full package, you only need to remind 10 patient provider dyads before their encounter or in between to actually get a reinitiation or initiation statin, which was really, really good. That's pretty efficient. Then the other sort of finding we found was, just like the providers told us at the beginning of this, is what they really wanted was to see it right before their clinic so that they could address it as part of the regular clinical workflow. And what you see here is when the alert was given, the way the providers preferred it, right before they saw the patient, you saw an increase, a relative improvement in the uptake of the reinitiation of the medication. And so in the next trial we're doing in chronic kidney disease and ACE and ARBs, we're not even allowing this. So we're going entirely to a synchronous structure and just restricting it to a synchronous type of alerting. And so in the end on this one, we did some qualitative post-assessment, not informalized enough to actually publish, but providers actually really did enjoy sort of the cognitive summary or the sort of summary of prior care relevant to this. And I would say this is an area where actually generative AI has a ton of opportunity, because you can point generative AI to a set of documents and you can say, synthesize the clinical care record relevant to this and that. And there's actually a bunch of funding and a bunch of projects going on to do that, because this is not very scalable. So we had to manually curate knowledge management. We had to manually curate the medication classes, the alerts. We're doing it again for another trial, but when you start to sort of think about Gen AI for this use case, you could see that you could scale it very quickly. And then the other heartening thing was only about 10 reminders needed to be sent for a patient to be restarted. But again, as I sort of already really emphasized, there were some informatics limitations, even in the context of a sort of a better mousetrap for clinical decision support in terms of tailoring the information, that I think has more room to grow. And so overall conclusions, I hope I sort of gave you a flavor for some of the fun that can be had in this sort of space. I mean, I really enjoy doing this sort of work. And I think the area of Gen AI is so hot right now. I would actually say, it's not on the slide, but I would actually say, I think supervised machine learning still has a very strong place in healthcare. And that even though the hype is all in Gen AI right now, I think we should not lose sight of the utility of more traditional machine learning methods, because neither of these examples used Gen AI, and they both had a significant clinical impact in healthcare delivery. And then the other thing I would say is that it takes a village to do this. It takes data science, qualitative mixed methods assessment, implementation science, and sort of user interface design. And so it's a bit of a challenge to deploy in clinical practice. So I obviously have to acknowledge a number of funding sources from the VA as well as NIDDK and NIH, large research teams. Sorry for the scrolling. I tried to eliminate that, but my slides just refused my elimination. So a large group of folks on both the Improve AKI trial as well as the PCDS trial. And the last thing I want to get to, if my slide will ever let me. This is almost just sort of a comedy routine there. Come on. All right, is the center that we direct at Vanderbilt, that I direct at Vanderbilt, is Population Health Informatics Center. Just really none of this work would be possible without sort of a matrix organization of biostatisticians, data scientists, database engineers, and faculty that sort of focus. Like you see some faculty focus in human-computer interaction and user interface design. Some are more implementation science. Some are more foundational in natural language processing and translational and risk modeling. And it takes a large team, and I'm very grateful to the group's expertise. So I'm happy to answer questions, and thank you very much for your time.
Thank you so much for a wonderful talk. I'm going to start with any questions here in the room. We have just about 5 minutes in the hour. I know people have questions. No, you should go ahead, Katie.
Oh, okay.
That was a really great talk. Appreciate all your insights. So thinking about correcting model drift that you find or detecting it, if we're thinking of supervised learning as an example, what are the types of things that you're doing methodologically? Just in it from my naive perspective, I would think about the y-intercept being a major problem. Like you're reducing some complication or some outcome. Is it really the factors on the right-hand side of the equation and their association with your outcome that's changing? Or is it really just maybe we're getting better in general and we just need to be thinking about the prevalence changing? How do you do that methodologically?
Yeah, it's a really good question. I mean, and I think Sharon's approach was to try to not know which one was going to happen and try to accommodate a surveillance framework to sort of detect any cause. So the method that she uses really just focuses on the predicted value and the observed value as they accumulate prospectively, and looked for deviations in the performance of the model. And then when that's found, then to go in and try to adjust it. But you're right. Like the easiest thing to correct is a baseline event rate, an outcome event rate drift. That you want to have happen with your interview, like you want to have something, so you're expecting to see those. But what we found is a lot of subtle association drift between the weights between variables, and we're still trying to figure out if that's documentation and sort of clinical sort of workflow practices, or if it's true, sort of change in clinical care. And I think it's a little bit of both. I don't know. I prefer the agnostic, because you don't know which of those environments you're going to. So I prefer the agnostic system to try to just adjust it no matter what happens. But I do see literature coming out that tries to be a lot more sort of intentional about targeting subcomponents of that and addressing it up front before it even starts to fail. So there's an opportunity in that space for sure. It's a tough problem. although I will say when this early work was done in 2017 to 2019 and 2020, there was a lot less being done. At this point, Microsoft has a whole platform in Azure that they published to do algorithm surveillance. And so right now there's a lot of sort of work going on around sort of providing surveillance tools to the user community around helping them watch their models and keep them going.
So lots of questions I could ask, but I was reminded of Nancy Lorenzi's people process technology, and that the people and process part is sometimes much larger and more important than the technology. Do you think, given the basis of your work, that we should be adapting our education programs in data science, biostats, informatics to have a greater emphasis on these qualitative workflow components that are so critical to these intervention success? Or would you say that we should really just be establishing greater partnerships between different units, or both?
It's a really good question. I guess I would separate it into broad and deep. So I think there's sort of basic competencies that anyone in sort of the clinical informatics space is going to need, and exposure to those, to understand that they need them and to understand the basic components of them, I think is critical in this. But it's hard to sort of develop a deep expertise and competence and then keep it up to date over years with the field changing. And so I think it's probably more likely to have a multidisciplinary team approach to sort of successfully executing these over time. So I definitely agree that there needs to be more integration of training, but I think it's more of an exposure and an awareness and a need of making sure that those stakeholders are in the environment that's attempting these sorts of things. And we haven't even talked about the democratization and sort of low resource centers where you'll have healthcare systems and environments and public health facing pieces that don't have a lot of resources to do this sort of. And so there's a lot of interest right now in the research community with trying to figure out ways to sort of standardize and sort of really make these a lot easier to deploy. And so that there's a large education component and capacity component to that as well. Great question. Tough to.
All right, we have one last question
Yes.
from our online audience about your thoughts on moving toward opt-out versus opt-in models for these kinds of clinical decision tools.
So because it's a really,
Whether
really,
that's a too aggressive approach, or are we there yet?
oh, it's a great question. And so I was a clinical champion in Nashville for the primary care physicians because I practice in one of the clinics that there. And so trust me, I got good feedback, both sides for the intervention, because this was routine care and because it was stuff that's already being recommended. And because the AI deployment was supported and not sort of autonomous or trying to make a decision for them, the IRB was okay with an opt-out approach. But even then, that's just the first layer. Then we had to go to the primary care leadership and the chief of staff in both institutions, show them what we were going to do and get their buy-in that it was okay for us to turn it on and an opt-out, because had they not sort of bought into that framework, we would have been we would have been opt-in instead of opt-out. And I think honestly, busy care providers in the middle of the pandemic that have a lot going on are not extremely likely to opt in. So, but I think it's incumbent upon those of us that are trying to design and develop and deploy these sorts of tools to do everything we can to make them not add work, but actually to subtract work from their processes. If you're not trying to do a net gain, then you're part of the problem and not part of the solution. And I don't know if I think we're probably slightly on the side of part of the problem in this one, but I think the lessons that we've learned from all the different pieces will make, I hope, this next one net positive.
Excellent. Well, thank you so much for a wonderful talk, and thank you all for being here.
Thank you all very much for the help.